Pleasure to introduce our next symposium. I will be co-moderating with Dr. Dobbs. We put together a symposium looking at the latest and greatest in terms of controversies, topics, as far as cervical spine technology, and questions that we often get with these topics. We put together a great slew of speakers and topics. I'd like to point out that there is one additional talk in this session from Samuel Cho, looking at different materials for the use of interbody cages as well. So without further ado, I'd like to introduce our first speaker in the session, Dr. Dan Riew, who will talk about total disc arthroplasty in the elite athlete, considerations for outcome stability, and wear debris.
Thank you so much, Wellington, and congratulations, Mike. And I congratulate all of you for getting up early enough and sticking around until the very end. These are my disclosures. I do get royalties for fusion devices and have stock ownership in some companies that sell artificial discs. So cervical disc replacement in athletes is the great unknown. We're just starting to put in arthroplasties in athletes who play contact sports. My first one was in a Cardinals baseball player, but he's not a contact sports athlete, and I did that probably about 15, 20 years ago now already. And he did well, but obviously it's not a contact sport. What we don't know is what happens in the long term. And if you were at my debate a few nights ago, we know that I do have questions about what the longevity of arthroplasty really is. So if you take a look at return to play after cervical disc replacements, I've done follow-up only for a few years and only a few athletes. It's not a huge experience of doing it in athletes who play severe contact sports, and no football players, for instance, and we'll talk about hockey. But predominantly, I've done it in UFC fighters, which is probably as violent as you could possibly get. I've done it in, as I said, a baseball player, an Olympic hopeful swimmer, an Olympic high jumper, and a UFC athlete, and I'll share this with you. This is an Olympic hopeful sent to me by her uncle, who's an orthopedic surgeon, and she had weakness in her triceps and a numb thumb and index finger, and we did her arthroplasty in 2016, and she went back to swimming about 3 days afterwards, and I asked her not to dive in head first, just to get into the pool and start swimming, but I told her she could return to swimming and diving at about 3 weeks. And then this is in the newspaper, so I'm not violating any HIPAA rules. Derek Druin was sent to me recommended that he see me by Tom Mraz at the Cleveland Clinic. He had seen a number of people who questioned whether a high jumper could actually undergo an arthroplasty and return to competitive athletics. And so I ended up doing his arthroplasty. You can see that the high jumpers actually really put their neck through a lot. And it was actually a high jumper who, in practice, ended up being quadriplegic. So it is a sport that this is the high jumper that was in practice and ended up quadriparetic. He was, after a period of time, able to actually walk down the aisle when he got married, and that made the newspapers in Canada. In the United States. But Derek Druin had this, but unfortunately afterwards he couldn't really compete in the subsequent Olympics because he had an Achilles tendon injury, but he's gone back to practicing and so on. And then this was on the internet, mixed martial arts or UFC. This is Chris Weidman, who was a UFC champion. And these guys are really violent. I mean, they're trying to kill each other, basically. You're allowed to kick them in the head. You're allowed to wrestle them. You're allowed to torque their necks. You're allowed to wrestle them, punch them in the face. And people, this is an incredibly violent sport. And when you're down, unlike boxing, you can get on top of the guy and beat the living daylights out of the guy's face. So you can just imagine what kind of violence the head and neck is subjected to. And it's just an absolutely brutal sport. I was actually invited to watch him at Madison Square Garden with my wife, and neither of us were that interested, so we actually didn't go. But he had a herniated disc at C6-7, and again, this is all on the internet, so I'm not violating any HIPAA. And I did a transcorporeal discectomy where I drilled a hole through the C7 vertebral body, went down to the disc, and just plucked out the disc. And then I took an allograft, cut it to the same shape of the hole that I made, plugged it, and he did very well. I let him return. He's got a YouTube video showing how he took out his own drain the next day, his x-rays, and this is a CT 2 years later, and you can see that there's no hole there. It's been completely incorporated, and he looks like he's had no operation. He went back to fighting, and then 2 years later, he ruptures another disc, this time at the C5-6, and this time it's a broad-based disc. It's not a unilateral that's migrated behind the vertebral body, so I did an arthroplasty on him in 2019. And again, he goes back to fighting, but if you take a look at the picture on the left, you see he just kicked, and he did this to another opponent, and he breaks his tibia fibula. I can't imagine how much pain that would be, but it's just it's a pretty gross picture. And so that laid him up for a while. I've also done it in elite collegiate wrestler who's gone back to wrestling, and did an arthroplasty on him about 1.5 years ago. And then everybody, I think, knows about Jack Eichel's story. Chad Puznak recommended that he talk to me because Chad was going to do the arthroplasty. He asked me if he thought it was an okay idea to do an arthroplasty because of my experience with Chris Weidman. And so I said, I think hockey is entirely reasonable. It is a violent sport. You obviously can have tremendous violence and fights and whatnot, but I don't think it's quite as violent as UFC. And the refs will break you up. And since then, Tyler Johnson's had an arthroplasty, and so a number of people now are probably in the wings to get arthroplasties. And finally, a baseball pitcher in 2022. He's actually done well. We treated him non-operatively, and again, this is in the internet, so it's not violating any HIPAA. And so in terms of non-professional sports, I've done patients who do jiu-jitsu. That's a pretty popular sport in the New York area. Karate and judo and wrestling, non-professional hockey and weightlifting, basketball, baseball, softball, et cetera. And there are some softball players that really, at the professional level, that really do a tremendous amount of, if you see them throw the baseball, I mean the softball underhanded, it's like throwing my ability to throw overhand. And then there are surgeons that we've operated on. There's a shoulder surgeon on the left, and this is a spine surgeon on the right, and this is a couple days post-op. Yeah, I don't think that's going to play, but he's sitting there, he's lifting something like 60 kilograms over his head. He drops it down, walks over to the camera, turns it off, and then texts to me and says, you know, I have gone back to operating the day after. Actually, he saw patients on the day of surgery, apparently. So in conclusion, CDAs are definitely here to stay. More and more athletes are going to be getting artificial disc replacements. And these fulfill a short-term need. These athletes need all of their range of motion. They need to go back to training immediately. And so if you do an ACDF, you're going to hold them back a little bit until the bone fuses before you let them back into serious contact sports. With a CDA, I also hold them back until I know that the artificial disc has incorporated into the bone. And so there is that waiting period, but you don't have to immobilize them in a collar. They can start training and not sparring if they're in UFC. I let Chris Weidman back after 6 months and after I got a CT to make sure that everything was incorporated. And I was very careful with him because he was one of my first. I've done subsequently other UFC fighters that I can't disclose because they're not on the internet, but and I've done hybrids with a one-level ACDF and one-level fusion in athletes that have managed to go back to playing various sports. So I think it is a good thing, but what we just don't know is what will happen in the long run. But for most of these guys and women, what they're interested in is in the short term. They want to be able to go back to their sports. They're willing to sacrifice the fact that maybe 10 years from now, we have to take that artificial disc out and convert it to a fusion. And so they're willing to sacrifice the long-term gains for the short-term gain of being able to return to their sports, because every year that they're fighting or playing a sport means millions and millions of dollars, not just in their salary, but many tens of millions in the endorsements that they get. So thank you so much for your kind attention this morning, and that's it. Thank you.
Thanks, guys. Those were great talks. I have a question for Dan. Dan, there's such variability and constraint of disc replacements. When I'm operating on like an athletic or a high demand person, I'm thinking, do I need to change which disc replacement I'm going to use, a less constrained versus more constrained? Can you talk about how you think about that when you're like operating on a UFC fighter or somebody, that person that's going to go through extreme range of motion?
Yeah, I just don't think there's any biomechanical data whatsoever to guide us on this. They all go through biomechanical testing to get FDA approval. But I think that for all the artificial discs that are out there, I think the patient's native bone is weaker than the implant. And so if you subject the neck to serious forces, I think it's the bone that's going to give before the arthroplasty.
Jim Hare, Philadelphia. Dan, not to pick on you, great talk. Your symposium was fantastic, everyone. Still not using titanium because it looks ridiculous, but that's a different comment. Many of the people with your pictures and your MRIs, I would have done a foraminotomy on. And I just want to know where, we often forget about foraminotomy because our anterior approaches are so great. And I'm sure these people had neck pain or other reasons to do it. Do you do foraminotomies, and where does it fall in your role? Because for an athlete, to me, I think that's the single greatest operation.
Yeah, so the transcorporeal discectomy that I did on Chris Weidman, that had migrated behind the vertebral body. It was a pretty sizable disc, and he also had a significant neurologic deficit in his triceps. And for a UFC fighter to not have triceps, he's out. He goes from #1 to like not even qualifying.
So, I mean, I get the ventral compression on the cord, but a lot of your patients had lateral discs, and I'm like, oh, I would have done a foraminotomy. And don't get me wrong, I trained with a very aggressive foraminotomy teacher, Fred Simeone. Thought everything could be done from behind, but it's just an interesting, and we tend to forget about that operation, which I think is one of the greatest operations out there.
Yeah, I agree. I think that a foraminotomy and discectomy works very nicely. My indication is that anytime somebody has any significant neurologic deficit, I prefer the anterior over the posterior. And the reason for that is that the foraminotomy works about 92 or 3% of the time and gets great results. But in the 5 to 7% of the time when the patient still has persistent symptoms and you get an MRI afterwards, you sit there and say, is that scar, you know? And even gadolinium doesn't help you differentiate. And I've had cases where somebody, either as a surgeon or something, critically needed their neurologic function, and the foraminotomy didn't work. The shoulder surgeon that I showed, I did a foraminotomy on him. He did great for a period of time. And then afterwards, he was so-so. So I ended up doing an arthroplasty on him, and then he actually got better. So whereas an arthroplasty, you can be positive because you see the nerve root, you see everything in front of that you've taken out. You're 100% positive, and the recovery rate is much faster because you're not disrupting the posterior muscles, whether you're using a tubular retractor or you're using an open dissection.
Michael Gerling from New York. Great symposium, and all of the talks were interesting. Again, I wanted to talk to Dan about a question. So in my experience, or at least I feel like maybe I'm off with this, but I'm not sure. Do you think that there's a difference in sort of evolution and mechanism of onset of symptoms? So like a UFC fighter gets slammed and goes from nothing to having a disc herniation, versus somebody who maybe had an evolution over time? Because I start thinking about the facet joints and maybe residual neck pain after an ACDF. And I wonder if it's not just arthritis, but also disruption of the capsule, in a very, very high mechanism accident, like a car accident, a punch, a slam, whatever it is. So, I mean, do you find, like, posterior neck pain, you're worried about the facet capsules and whatnot being disrupted?
Oh, absolutely. So I look at the MRI to make sure that there's no intensity, increased signal in the facet joints. We get flexion extension views, and we make sure that there's no soft tissue, high intensity signals in the dorsal spine. But amazingly, most of these athletes will tell you it wasn't because of an event. They say I was in training and all of a sudden I had this pain, then it got worse, and we try to treat them. Chris Weidman, we had him going for 4 months on non-operative treatment before we actually operated on him. And so you treat them identically to somebody who's not a professional athlete as much as you can.
Mm-hmm. Yes, thanks.
Yeah, I had 2 questions. Just a quick one for Dr. Riew. You mentioned you like to wait until there's bone ingrowth to return to contact. I treat a number of collegiate wrestlers, and they want to go back right away. You put that implant in, and I've had times where I put it in and I think, maybe I want to change something, and you try to get it back out, and they have a tremendous amount of initial rigidity. They're oftentimes hard to get back out if you wanted to modify something. So that experience has led me to believe that you probably can go back really, really quickly. And I don't know that the bone ingrowth is absolutely necessary, but I wondered your thought on that. How long would you restrict someone like a collegiate wrestler or Chris Weidman if you were to operate on him again now?
Yes, I agree. I think that they're more stable than we give it credit for. I wanted to be extra careful because, when he's splashing all of this over the internet, the last thing I wanted was to have this pop out while he was in a tournament. And but for collegiate athletes and so on, I led all of these guys back to training, so they just can't spar. But they can lift weights, they can exercise, they can run and jump, and et cetera. What I don't do is let them spar, and I think the collegiate athletes, I would feel pretty comfortable at 3 months now, letting people back to doing those things.
Dan, in the context of the informed consent conversation that you're having with the select patients you're talking about, any pearls of wisdom for the audience about how to conduct that conversation? How to make sure that they understand the assumed risk? And what does your documentation look like that potentially covers your flank if something goes wrong?
Yeah, so by the time they come to see me because they want an artificial disc replacement. And so convincing them about getting the artificial disc replacement is almost never a concern, whereas convincing that they should get an ACDF instead, that's when you really get pushback. And so what I tell people is this: I've been doing it since 2002. That's 20 years. And so I think it's wrong to say that this is really a new device. That's like saying that you really shouldn't be using this because it's such a new device. It's only been around for, maybe 15 years. Well, arthroplasty has been around for 20 years. It's one of the most extensively studied devices that we implant in human beings. Better studied than total hip replacements, total knee replacements, than anything else. But I also tell them that we don't know what's going to happen in the long run. Biomechanical studies done by Paul Anderson that I was a co-author on showed that the original Bryan disc, it probably will last over 100 years. But we don't know what happens in the human being. There's osteolysis, there's heterotopic ossification. These things are probably going to wear out, because if you put it in somebody in their 20s, by the time they're 90, it is highly unlikely it's going to be around. And so I tell them that it's an unknown, but most of these people are incredibly well informed. They have actually read the literature, and they have studied. They come quoting my articles and my YouTube videos, things that I didn't even know existed. And they say, "Oh, I saw you on the YouTube video." I said, "I didn't know that it was a YouTube."
The challenge is the people you're talking about, that little subset, are people potentially subjected to extremes of force. Mm-hmm. Everything you just said is great in the normal population, mm-hmm. But any pearls of wisdom, particularly in the medical legal environment of the United States, for that potential extreme circumstance?
Yeah, I don't, unfortunately, John, you're much better at talking to patients than I am, I think, and I do get an informed consent. I have a handout that I give to patients that explains things, but I don't really specifically detail every little thing. What we do in many cases is an unknown.
Yeah.
Great. I want to thank all the speakers for a great session. Thank you.